next presenter, Dr. Eugenia Sigler.
Thank you very much, and thank you also to the audience for your interest in this topic. Next slide. Just to comment that I have had some support from Gilead. Next slide. Steve finished with his comments about GMHC's support programs for long-term survivors. This slide is sort of a reminder that while we are talking about general groups of people, and I will continue to do so, we have to beware of generalizing too much. Even the term long-term survivor means different things. It can mean the population we're talking about now, those who've acquired HIV in adulthood, or anyone who acquired HIV in utero becomes a long-term survivor when they reach adulthood. And as Steve has mentioned, older adults also develop HIV late in life. These groups have different needs, and so while we know that everyone needs help and support, they are different. Next slide. So what I want to do in the talk today is acquaint you a little bit with geriatrics and some of the models of care that are being used to create clinical programs for people with HIV. I'll talk a little bit about our program at CSS, and then some general thoughts about the challenges we face in applying geriatrics to the different needs of people with HIV. Next slide. So when we talk to providers, we want them just to begin to think about what's happening to the older person with HIV. And sometimes that begins with just a basic question, is this person old? You have to ask, are they thinking about aging? I've had patients who've said that this topic has never come up, but they've wanted to address it. Does the individual feel old? And from our point of view, would this person benefit from a geriatric? Let's think about these older people with HIV. They all are different. And we have seen people who've been newly diagnosed. We've seen people who've lived with the disease for a long time, men and women, people who have family supports and who don't, people who are supporting their family, people whose family are in conflict over them. There are any number of both medical and social needs that we have to think about. And so any program that wants to have geriatric attached to it needs to think about how are we going to, or can we even meet the needs of all these older people with HIV. Next slide. Now, I mentioned what the definition of a geriatrician was, that's limited in value because it doesn't say what we do. And the British and the American Geriatric Societies recognize that, and they've come together to suggest that there is a geriatric approach that can be summarized as the 5 M's. And those are mind, that is cognitive, affective, other mental health issues, medications, are people on the right drugs and nothing but the right drugs at the right doses, multimorbidity, you've heard that already from Steve today. Some people also refer to this as multi-complexity, so that the other problems that older people have, geriatric syndromes, for example, are part of this. Mobility, how well are people getting around? How well do they walk? Do they need an assistive device? And the last, but in many ways most important, what matters most, that is, for older people, a significant portion of our time is devoted to figuring out what their priorities are and how their health care will reflect those priorities. Next slide, please. UCSF has done a lot of wonderful work on this, and Meredith Green, my colleague there, has a wonderful geriatric program. This was some of their preliminary work, what they called the Silver Project. I just want you to look at some of the numbers. I'll walk you through the slide. So these were a number of people, older people who were cared for in this original program, about 350. And if you look on the right, as Steve has mentioned, the majority, but not exclusively, were MSM. 30% were smokers. The median number of medications they were on were 11. 40% had fallen in the last year, and about a third had some level of cognitive impairment. As you can see, again, about a third were lonely and about a quarter admitted to being moderately or severely depressed, and only half had normal social supports. The table to the left divides that group into those between 50 and 59 and those 60 and above, and not surprisingly, as you would expect, more people in the 60 and above group had balance problems than those in the 50 to 59. Fewer people over 60 had what they would consider excellent or very good health, and they had more trouble walking. What I draw your attention to, though, was that people 60 and older had better medication adherence than their younger counterparts. And this is often what we see. What I think this underscores is that while med adherence is crucial for people aging with HIV, it's not the only thing that we should be worried about. Adherence to antiretroviral medications is where we begin, but really our clients, our patients have a lot of other needs that we have to pay attention to as well. Next slide. So we mentioned comorbidities, and I mentioned something called geriatric syndromes, or what I like to refer to in this population as aging-related syndromes. And those are clinical conditions that don't fit into discrete disease categories. You can have coronary artery disease, you can have diabetes, and you understand what we're talking about. Aging-related syndromes are very common, but they're hard to pin down. And falling is an example of one. Dizziness is an example of another. And you have heard Steve comment about, and you probably read about something called frailty, which is the classic and in many ways most worrisome aging-related syndrome. Next slide. I want to take just an extra minute or two to talk about frailty because it is, again, hard to envision. It's important to recognize that frailty does not mean disability. What frailty means is vulnerability, and we have seen in the HIV literature that it interacts synergistically with other problems to increase mortality and functional decline. We know that if one gets to the point of marked frailty, it's very difficult to reverse, but early stages of frailty, what some people call pre-frailty, it is reversible if you can get people out of their apartments, if you can get them exercising, if you can get them recognizing that they're in danger and they're vulnerable and in need of extra help. Next slide. So comprehensive geriatric assessment, that is all the things we're interested in, incorporates a variety of domains. And we start with things like geriatric syndromes and comorbidities, but we're looking at things beyond the medical. So we are interested in the activities of daily living, both the basic ones and the instrumental activities like managing finances and medication. And of course, medical comorbidities, but we also cover nutritional status, whether the medicines are correct, what the social network and financial status are, affect cognition, quality of life, what their living situation is, and again, what their preferences are. Next slide, please. So you can imagine that now with a majority of people in New York State and around the country over 50 and a significant number of people over 60 with HIV, who might benefit from comprehensive geriatric assessment? And this is one of the fundamental questions we have yet to ask. You know, should all programs have some sort of screen? Whom would we screen? And there are many, many different ways to think about this, and we don't know the right answer yet. One way would be totally age-based. Another would be asking patients, you know, do you want to talk about aging? A third would be taking one of the elements of geriatric assessment and focusing on that. You know, should we screen people who are complaining about their memory? Should we screen people who are taking a certain number of medications? We're so new at this, we don't even know who will benefit from comprehensive geriatric assessment and who should be targeted. So what kinds of model of care currently exist for older people with HIV? Next slide, please. I'm going to talk a little bit in a few minutes about our program, but there are a lot of programs that are developing all over the world. In New York, I draw your attention to the Bronx, where Anjali Sharma is beginning a program to try to screen people who would be appropriate for geriatric assessment and perhaps even have an integrated model of care. But all over, different people are trying to figure out should they do comprehensive geriatric assessment, should they be age-based, or should they focus, for example, on physical problems? And then once they screen, what do they do? Next slide. There's some really exciting programs also, or studies that are looking at other aspects of geriatric care, case management in terms of this model in Hong Kong. In Italy, there's a study looking at mobile technology, both to connect people and to give them coaching and get some sort of sense of how to motivate them and how to get them moving again. So it may end up that some of the most innovative programs are going to be social interventions, and perhaps less so the comorbidity and the screening. I think there are many exciting opportunities out there. Next slide. So what are we doing? Well we have the most sort of geriatrician-focused. Two of us geriatricians do consultations, and we are embedded roughly one half day a week in the HIV clinic. And this started with just some joint conferences, and then I got some foundation support for us to do geriatric assessment on referred patients, as well as do some arts programs and a few other things. That funding is completed. We still, as geriatricians, see patients at CSS, but one of our challenges is figuring out how to create and sustain the community linkages that we think that our patients need. Next slide. If any of you are clinicians or work with clinicians, you may recognize a screen from Epic, one of the electronic medical records on the right. What we've been able to do is create a screen within Epic so that we can enter our data fairly quickly. And we do a comprehensive geriatric assessment that includes a history of physical and, again, some of the discussions of ADLs. We ask the PHQ-4. We talk about vision and hearing and quality of life. We do a Montreal Cognitive Assessment. We do some background, use the background tools, FRAX to look at bone health, VAX to get a prognostic assessment. Next slide. Our patients are referred to us. They can certainly ask themselves, or they'll be referred by social work or psychiatry or their primary care provider. this is opt-in, not opt-out. And as it turns out, the most common reason why people are sent to Dr. Del Carmen and me are cognitive concerns, people worried about their memory or people whose clinicians are worried about their memory. So these are just the issues that come up in discussion, and the commonest concern as expressed were indeed cognitive. The second one was community services, then down function, comorbidity, all the things that we do in geriatric assessment, other things, smoking cessation, chemical dependencies, bladder problems, and a variety of other topics. Whatever people want to talk about, I am happy to talk about with them. Next slide. Now, what happened as I was talking with patients was it became clear that we ended up fairly frequently talking about goals. So I made that a standard question I ask everybody. I just ask them, what are your goals? And as you can see, there are a wide variety of goals, but the one all the way, the bar all the way on the left is a sobering reminder that many patients were unable to state a single goal. Many felt hopeless enough that they couldn't think of a single thing that they were looking forward to. The number one goal for many others was staying alive, and then better health. So the existential issues that come up in what should be a general geriatric assessment have been quite sobering to me, and again remind me of how broad the topic is that we have to cover, and how deeply troubled many of these survivors, many of these older people with HIV are. Next slide. So, we all thought that we're uncovering a lot. We made a number of suggestions, and this is from a retrospective study we did on how effective we were. Now, this is based on recommendations on that first assessment. I do see most patients in follow-up, but on the first assessment, we made a number of recommendations, some of them directed toward the patient, some of them directed toward the provider. The bottom line here was that only about a third of recommendations that we made were actually implemented. Next slide. And when we did a separate questionnaire online, just saying, how do you like the geriatricians? And of course, most people said they thought we were very helpful, and most people said that they implemented the recommendations. But we could not quite understand the discrepancy between the generally positive reviews and what actually happened, and we asked why. Next slide. So why this discrepancy? And we thought about a lot of things. First is I do think it takes a while to develop trust, and after multiple visits, I find that I can, I think, work more closely with patients. When you're a consultant, you can't change what you don't control. You can make a recommendation. You can say, I think it would be great if you could do such and such, but you can't. You are walking into a situation where you don't know all of the issues at hand, and so what you think makes sense from the textbook end may not make sense. It's the third and the fourth, though, I think that are very challenging to me, and what I want to talk about in more detail as you begin to think about what you want to create, what you want individual clinics to do. And that is, we don't know if what works in a geriatric clinic, and how I was trained many years ago, whether that works for older people with HIV. And we also recognize that the doctor's office is often not where healthcare happens. Next slide. So geriatricians are, trained and have a certain perspective, and you can see what we do in terms of comprehensive geriatric assessment. But we don't know whether that translates to people with HIV. Should I be doing the same kind of comprehensive assessment? What else do people need, and what am I missing? Next slide. Similarly, if I can do a comprehensive assessment of older people with HIV and get at what's really going on, what recommendations should come from that? What's feasible? What's useful? Are the things that that we normally recommend, are they really actionable? So how do we adapt geriatrics to HIV care? Next slide. And I'll give you an example. This is cognitive impairment. Again, the number one reason people are sent to me. I'm not a neurologist, so the focus from my point of view is identifying what troubles they're having and trying to help them cope with that. But this is a great study that was published in 2016, just displaying, this was particular graphic, displaying the contributions to cognitive impairment over time. So that if you look in the early 80s, cognitive impairment was due to active replication of HIV in the CSF. That's the red line, and that makes up the majority of the contribution, together with the ongoing inflammation caused by the presence of the virus that Steve had alluded to. As we have been the beneficiary of effective antiretrovirals, active replication is largely suppressed. Inflammation is less. Instead, you have damage that's due to disease before antiretroviral therapy was initiated, disease due to possible antiretroviral neurotoxicity, disease due to longstanding drug and alcohol abuse, but also what everybody else has and what you get when you grow older, the coronary artery disease, cerebrovascular disease, other neurodegenerative diseases. So the causes and the timeline of cognitive impairment not only have changed over time for people with HIV, but the whole clinical scenario is different from those who have never had HIV. So how do we as geriatricians work in the situation where we have a different population, where we have a population whose experiences are different from those 30 years ago, but also where their social supports and their long-term care options are different from what we were taught. This is just one example of how of the challenge we'll have in translating classic geriatrics into recommendations and treatment for people who are aging with HIV. Next slide. The other point that I want to make is that as much as I think it would be great for everyone to see a geriatrician and for geriatricians to learn HIV care, is that the numbers aren't there. On the right is the forecasted supply and demand for HIV clinicians from the HIV Clinician Workforce Survey. And you likely have seen data similar to this, if not this graph, where the number of HIV clinicians is continuing to decline, whereas the demand is continuing to increase. In terms of geriatrics, which is the bar graph on the left, the green, this was, I think, 2015 numbers. The green is the supply of geriatricians, which is only about 3,600. The textured bar is what the American Geriatric Society feels is the demand for geriatricians, many-fold higher than that. And I just threw in the number of cardiologists as a comparison. So we don't have enough geriatricians to go around for everybody. We don't have enough HIV providers, and that number is probably continuing to decline. How are we going to provide the care that we need to provide? Who's going to do this? And any kind of program or mandate about the kind of care that older people aging with HIV should receive have to take the workforce supply into account. Next slide. So I think in trying to put all this together, we need to understand who's going to do the primary care and how much time they should have. Who's going to do the HIV care? Will HIV and primary care be linked, or will HIV care be the purview of infectious disease specialists who will be asking general primary care providers to do the general care? Who's going to be responsible for the aging concerns? And what do we do about limited money and access for the clinic? That, again, is just what's going on in the clinic. And one of the themes I think we've heard today is what goes on outside the clinic is just as important. And we need to look beyond HIV social services to what geriatric social services or the Aging Services Network can provide, and figure out how to deal with those silos. Next slide. I've found that one of the most useful things that I've been able to do with the wonderful social workers with whom I collaborate, who just know everything about what's available for people with HIV, is introducing them to some of the things that are available through the Aging Services Network. And you know, every county has an area agency on aging, and one can find out what the local area agency on aging is just by plugging in a zip code or a city. The elders, you can do it through the National Association of Area Agencies on Aging or the Elder Care Locator. Next slide. We also have an Aging and Disability Resource Center, which is the No Wrong Door system that the HIV Services Network is not part of, but I think should be. And that's a fairly new and collaborative effort between CMS, Center for Medicaid and Medicare Services, the Agency for Community Living, which is the major source of federal support for disability, and the VA. And the idea is no wrong door. The idea is one phone number can get you linkages to resources from all these different networks. And again, breaking down the silos of HIV care, recognizing that many people with HIV are now eligible for services from other institutions and other networks, and figuring out how all of these can be accessed and we can make it easier for our patients to get whatever is available for them is I think, a high priority. Next slide. You've seen all sorts of groups of terms. This is what I've created sort of for myself, and Steve knows me well enough that he's seen this evolve over time. I want to make several points. One is that the biomedical, which I am supposedly focused on, is just a corner of all of this. The psychosocial interacts with that, but there are so many other concerns that the people I work with have, some of which are psychiatric, but some of which are existential. Some are just purely physical, and some of which have to do with unmet practical needs that I can't, as a geriatrician, focus on only the biomedical without recognizing how important all these other components are to an individual's ability to survive and to thrive. Next slide. So programs for older people with HIV share, many barriers to success, and as you begin to think about, again, what kinds of programs you want to support, there are a number of factors that we need to consider, perhaps you can look at the box on the left and say, well, that's true of everything I do. It almost certainly is, but if we're going to add another program, another area of concern, we have to address these issues head on. Next slide. So when we think about this, again, who's going to be referred? What, is there going to be a screening? What are the criteria going to be? How are they going to be assessed? Who's going to do the assessing, and where are they located? If you want to refer to a gerontologic nurse practitioner or a geriatrician, where are they located? And how do I get my patients to that person? When they have recommendations, what are they going to focus on, and how do they get that information back to our clinic? How are we going to measure success, and how are we going to keep this financially viable? And finally, what linkages are going to be created? How are we going to link to community organizations? How is this program going to relate to primary care? All these need to be determined when setting up any kind of program or when creating a mandate from the state about how older people with HIV are going to be helped. Next slide. So I also want to end with one other thing to think about, and that is, I've been talking about what I as a geriatrician can do in the clinic, and this is in the context of a history of examining or HIV and aging. If you think about it, work that Steve and his colleagues have done in the early 2000s were just making people aware of what was happening. Was creating a recognition, which then involved documenting the comorbidity and the rather impressive and complex medical needs of older people with HIV. As we begin to look at aging-related syndromes and how people now are not 50 but 60 and 70, we need to look at long-term care, not just nursing homes, but how we are going to provide care in the community. How are we going to reshape senior centers and other community-based organizations to make their services relevant and comfortable and welcoming? All of this, I think, needs to be looked at now, even as we are still struggling with how to identify these individuals and get them the medical care they need. Next slide. These are some resources that we have. The Northeast Caribbean AETC, which Cornell is a member of, has an HIV and aging toolkit with references and instruments and other things that you can download, as well as these other websites. And again, Steve's new website, endinghiv.org is just up and running within the past week, and I think will also be a wonderful resource. So there's some references here, and with that, I think I'm going to finish, and I think both Steve and I will be able to take questions.
Okay, thank you for that, Dr. Sigler. So as promised, the floor will be open for questions. We ask that you please send your questions to all panelists, but specify which one of the presenters your question is for. Okay, so please, you can submit your questions now. Okay. Okay, Jen, are you seeing the questions coming through on your end?
I haven't seen any questions come in yet, so just to remind folks, to be able to access the all panelist feature, your chat in the bottom, it'll say to, and you should see the option as host, presenter, or host and presenter, or you can do all panelists. You should see an option that says all panelists. If for some reason you do not, you can send your question to the host, which is me, and I can then divert the question to either Dr. Karpiak or Dr. Sigler, depending who the question is for.
Okay. All right, I think I see a question coming through, and I believe this question is perhaps for Dr. Sigler. It says, have you seen a rise in toxoplasmosis in older adults who are positive, even though they are undetectable?
I have not, although again, I want to make it clear that I am not an HIV provider or an infectious disease specialist, but certainly in terms of the cases that have been discussed or the cases I've seen, I've not seen an increase. I would have to look in the literature to see if others have seen that.
Okay, thank you, Dr. Sigler, for that response. Okay. All right. Let's see. I think we have another question here, and this one is also for Dr. Sigler. Why do we think there is such a low number of supportive services providers that have had contact with a geriatric specialist?
I would be inclined to throw that question back at you. I mean, I can hazard some guesses based on what people have told me, and that is, I think that there has often been a focus on making sure that the virus is under control, is undetectable, and that I've at least been told that oftentimes questions about aging never come up and even are not considered the purview. So I think the first is that there's just an I think people sometimes don't see that their client is aging. I think it's just, you have to step back for a second and look and ask that question. So if you don't see it happening, you don't make the referral. Similarly, my bet is that there are plenty of people in a clinic or an outpatient program or a social service organization who are using an assistive device, a cane or a walker, but that may not be viewed as an aging issue. It may be viewed in and of itself as a neurologic problem or an orthopedic problem. So that I think that the framing isn't there, and that's what I would hazard. I would love to hear what others have to say.
Okay, great, thank you. Another question for you, Dr. Sigler. Any suggestions regarding monitoring older clients who appear to be receiving poorly monitored pain management?
I'm trying to understand monitor. There are in academic settings and other places individuals who are developing expertise in management of pain syndromes and neuropathies in the setting of HIV. So the first question I would ask is who's managing the pain, and would this benefit from an outside expert who understands what is effective and what may not be effective. The second question would be, is part of the problem that the individual has a history of substance abuse or is susceptible, and that there is there are two things going on, and does the individual need help with managing a substance use disorder at the same time they are dealing with chronic pain? Both of those require, high levels of expertise, and I would not be afraid to find the right person to help your client.
Okay, thank you. This next question is now for Dr. Karpiak. When can we look forward to the ROA 2.0 study to be released?
We are just finishing up the Oakland white paper, which I expect will be done within a couple of weeks, and ditto for the Chicago paper. That will be followed in late October by the Upstate Rural, and then hopefully by the end of November, the large population study from New York City. I just want to mention in response to a couple of the questions, most of you work in the world of HIV, like ourselves, and yet the folks who know the most about aging are not people with HIV who work in the HIV domain. There are folks like Dr. Siegler, there are gerontologists, neurogeriatricians, etc. We need to bring them into the fold. We need to knock on the door and ask for their input and their advice and their guidance in all this. We often think that, as someone just mentioned, we turn to the HIV provider or those people who are knowledgeable about HIV management. But those folks do not know about the complexities of managing aging. We need to shift our focus to that level of expertise as we move forward. Thanks.
Thanks. And just let me just add that, or mention that, we'll do everything possible to get to your questions, but if we don't, I apologize in advance. So in the interest of time, we may not get to your question. But that doesn't mean your question wasn't important. Okay, so this next question is for either presenter. Can you talk a little bit more about isolation and any interventions that may be effective in addition to the ones Dr. Karpiak mentioned?
Steve, why don't you start first?
How to combat social isolation is a real serious challenge. Part of the reason it's a challenge is that one size doesn't fit all. You may define a social activity that's good for one person or one group, but it's not good for everyone. And I think that anyone who, for example, runs a senior center or takes care of people who are aging knows that that creating a socialization atmosphere or activity is kind of tough to do. Although sometimes it could be very easy. Something simple might go a long way. We've noticed that in one of our interventions, which I had mentioned there, We Are Not Alone, where about 15 to 20 people come together for this 2-day training. By the very nature of that group, and we have an interactive process, we actually begin to create a social network by that simple coming together. So I think we need some creative thinking around this one, and particularly because this is, by and large, a younger population. These are not people in their 8th or 9th decade of life. But it takes some effort, and there are very few funding streams for socialization.
I'll agree with that. A lot of the problem is just money. An example, we tried to set up a social support group for women in our program and could not get adequate attendance because we did not know enough to offer MetroCards. We basically could not get anyone to show up in consistently because they couldn't afford it. So I want to underscore that these programs require funding, and I would love to see some of the special needs providers or Ryan White or others build transportation and socialization into what they offer. I've mentioned to others that in geriatrics we have something called a PACE program of all-inclusive care of the elderly, that is for people who are dual eligibles, that is, have Medicare and Medicaid. And the feds give 95% of what it would cost to take care of this individual to the PACE program. And the PACE program is allowed to spend the money whatever way it wants to. Part of the PACE program involves socialization. The clinic is at the senior center. But one of the biggest areas of spending is transportation. You get to save a lot of money and spend it on transportation and socialization if you keep people out of the hospital. And I would like to see, obviously I'd love to see the state underwrite some of these initiatives, but I would love to see insurers underwrite some of these initiatives, because if we can get people to socialize and exercise and get them to programs, at least the regular geriatric literature has shown that this keeps people out of the hospital and ultimately saves money.
Okay.
Can I just make one quick comment? On the National Resource Center page, aginghiv.org, there is a map. It's a community map, and what we're doing is we're collecting across the country what activities people are engaging in. It could be just a few people in a city you may not even heard of. We want to make people be aware of what activities are being developed for older adults. And by doing so, we'll be sharing the thoughts and ideas and creativity of many communities across the country. Thanks.
Great, thank you. All right, here's another question for Dr. Siegler. I think this is an interesting question. As the general population ages, is there a program to educate geriatric specialists in infectious disease, including HIV, trauma, informed care, and social determinants of health?
There's a core of us who are interested in educating others. You brought up a broad number of topics, and what I'll say is geriatric fellowship generally tends to include many of those topics, especially social determinants of health. I am not aware of the American Geriatric Society or other organizations mandating training in HIV, but keep in mind also that when you go into a geriatric fellowship, you have already done internal medicine or family practice residency, and so my expectation would be that as all internists learn to take care of people with HIV, the geriatric world will build on it. But it's obviously you're talking about something that's very dear to me, and I would love to see something that is more formally included in the geriatric curriculum. I just don't think that we're there yet.
Okay, thanks. Okay, and this next question is for either panelist. Could you please comment on the role of sexual health and well-being among older PLWH, challenges, resources, research, etc.?
This is Steve. I think if you go to our page, AIDS is not a condom, you'll see the issue, not the issue, but the domain of sexual health addressed. Sexual health remains an important part of our health repertoire as we age. those people who engage in sexual activity have better health outcomes across the board. And I think we need to recognize that older adults are sexual human beings, sexual creatures throughout the lifespan, and that sexual activity is largely deterred by lack of function and lack of partner. But nonetheless, I think more and more we are recognizing the need for sustaining sexual health and at the very least recognizing that it exists and it's an important part of our healthcare.
Okay, great. And in the interest of time, I think we're going to take just one more question, which I will read, and then we will move towards the closing part of our webinar. So here's this last question. And again, I think this question is perhaps for Dr. Siegler. For those older persons with HIV who do have partners who are negative, what is your experience with PrEP and their openness to using it?
I have not counseled anyone specifically on that. I would say, again, my experience is working in an HIV clinic where I know social workers and the physicians and the nurses have these conversations all the time. Obviously, U equals U is very important, and that's part of the conversation as well. But I think that our program, for example, has a PrEP component and doesn't just see people with HIV. So anyone who was interested and who had a partner could easily be referred and seen within the same clinic, and perhaps even have a colleague or the same provider. So I think from my point of view as a geriatrician, we have a lot of work to do to merely test for HIV, as well as to have conversations about sexual activity, and that's one thing that we're trying to encourage, that these conversations begin everywhere. But I think that the people most skilled at having these conversations are the people who provide the HIV care, because they will always have discussions about safe sex, and will, if the individual patient or client is willing, have discussions with their partners about safety.